Welcome to week 9. This week we're going to look at a specific branch of the human services, chemical dependency counseling, and look at the ethical issues that are unique to that area of human services. And this matches one of the discussion board questions from this week, where you are asked to pick an area in human services practice and look at its own unique ethical issues. We're going to look at several issues that are unique to the chemical dependency profession. It's not an exhaustive or comprehensive list, but just some examples. For example, we haven't included boundaries or dual relationships in this list, so there are many examples of that in the chemical dependency field. This is just a brief introduction to the topic, and also an example of how you might write about it when you write your discussion board this week. So we're going to look at who is helping, some competency issues, issues around informed consent, around mandatory treatment, about duty to warn, about needs versus resource limitations with our clients, and about denying or terminating treatment. And we're going to look at it through the chemical dependency profession slant. So first of all, we want to ask, what is a professional? And one definition of a professional is a group of people who share a common body of knowledge, a code of ethics, and a concern for their peers. So who then is providing chemical dependency services? Well, there are many people at many levels involved in chemical dependency treatment, sometimes as individuals, sometimes as part of a multidisciplinary team. All of these professions have different qualifications, different guidelines, different ethics codes. And then the field also utilizes peer counselors and volunteers. And the level of education needed to provide services and to be qualified to provide services is less than in other helping fields. So as I mentioned, there are peer counselors sometimes. In the AA program, we have sponsors who are volunteers. In our state, to become a chemical dependency professional trainee and then a licensed chemical dependency professional, you only need an Associate of Arts degree or a Bachelor of Arts degree. That meets 45 credits of coursework that the state requires. If you have a master's degree, currently you still need those 45 credits of coursework, but we're moving towards a time when you'll just need 15 additional credits of coursework because it's recognized that someone with a master's degree has all the basic skills and just needs the coursework and how to apply those skills to this particular population. In addition to counselors and mental health professionals, physicians, clergy, psychiatrists, psychologists, private practice therapists, probation officers, there's many different professions that are involved in chemical dependency. So which code of ethics should be followed? There is a code by NADAC, the National Association of Alcoholism and Drug Abuse Counselors, and this code seems to be most specific to the issues that one would encounter in the chemical dependency field. Let's look at what some of those issues might be. Here are some examples of competency issues. For example, workers should be able to explain the differences and efficacies between treatment modalities, and this is not often the case. If you work in a particular program with a specific treatment modality, you may just only be explaining your modality to the client. Another question or issue is, can non-healthcare professionals explain to clients about medications? So, for example, like opioid replacement medications or medications that help people to deal with alcohol withdrawal. Often, as chemical dependency professionals, people are asked to be able to give clients all the options, but do they have the medical training to do that? And clients with chemical dependency problems come to their counselors with mental health issues, legal problems, marital problems, issues around sexual dysfunction. Can the chemical dependency professional help the client with these issues if they're not trained to do so? Can a chemical dependency professional work with any population, even if they have no experience or knowledge of the special needs of that population? I would say no to those questions, that we should not be working outside the bounds of our competency. Can a chemical dependency counselor treat other addictions, gambling addictions, sexual addictions? I think you need special training to do that. How about this thing I've heard very often, that only if you're in recovery yourself can you effectively serve clients with addictions. And if that's the case, how many years of sobriety is required? And since relapse is a part of recovery, it's possible that the counselor could relapse. And so does that mean that they are no longer able to work in the profession? These are questions that the chemical dependency field is grappling with. So one way to address some of these competency issues is to work as part of a multidisciplinary team and to build a good referral network that will help your clients to deal with the issues that you are not qualified to help them to deal with. And also to make sure that your skills are up to date and that you're knowledgeable about the field by going to continuing education and other ongoing training opportunities. What about the client's ability to provide informed consent? Sometimes our clients come to us with some cognitive impairments related to chronic alcohol abuse, or they might be under the influence of some drug during the intake process when you're trying to help them get into a detox program. Maybe the client is from another culture and does not understand some of the concepts you're explaining, or the client is a minor and you're not sure what the age of consent is for the client to enter into a drug and alcohol program without parental consent or knowledge. Is a minor capable of making an informed decision? And what about mandated clients? We've talked about them this quarter in terms of having the choice of going into treatment or going to jail. Is that a client who can really make an informed decision? And we have had some discussion about that and said yes to some extent. But let's talk about that just a little bit more. Courts mandate treatment in lieu of jail time. Sometimes clients are mandated to go to treatment or else lose their parental rights, they'll lose their custody of their children. Or if they've gotten a DUI or several DUIs, they might risk losing their driver's license unless they go into treatment. Employee assistance programs require employees to go into treatment as one requirement for them to continue working in the organization. And sometimes clients are asked to enter into treatment or to maintain benefits from the state. In this process, clients often have to waive their confidentiality rights because the courts or the CPS or the employer requires reports from treatment counselors on the client's participation and progress in the program. In this case, the chemical dependency worker should negotiate in advance with these entities about what should be shared and the frequency with which this information will be shared as part of the informed consent process. They should be letting the client know these things. In terms of confidentiality, the issues around duty to warn and reporting are also these. For example, if you know your client's job responsibilities are such that being intoxicated or hungover would threaten the lives of others, what is your duty to warn? We had a case about that with the nurse and the client who was using marijuana and alcohol and not taking his seizure medication, and it's pretty complicated. Or if a client is endangering his own life by riding in the car as peers who are intoxicated. Or if you know that she or he is driving while impaired. What about a client who has HIV and AIDS? How do you protect the client's confidentiality around this, but also protect client sexual or needle-sharing partners? What about the use and abuse of drugs and alcohol by pregnant women? Or the fact that some states define child abuse as witnessing out-of-control drug use or illegal drug abuse. Also, we have to think about suicide risk with those who have chemical dependency issues and how we would handle clients who are threatening suicide. So not all of these have clear-cut answers. Use and abuse of drugs and alcohol by pregnant women, there is an obligation to report those things to CPS, but you need to also for all of these, really, get consultation, both supervisory and legal consultation before proceeding. What about the ethical issues of providing services or not being able to provide services because of resource limitations? One of the most common reasons that chemical dependency agencies or caseworkers are cited for noncompliance is that they are not complying with the standards of care that are advocated by the American Society of Addiction Medicine. And that may not be because they don't want to comply, but because there's no payment mechanism for the client to enter into treatment, or there are no treatment beds available, or the managed care program has denied the client the services. What is the worker's ethical responsibility in an environment of limited resources? And if your program has a waiting list, how should clients be prioritized? Based on their need, based on their ability to pay, based on your perception of whether they're ready for treatment, based on who got to the waiting list first? These are not, again, easy issues to answer. If there's only a substandard treatment program available for the client that doesn't entirely meet their needs because they don't have money to pay for the one that would meet their needs, how do you as a worker deal with that? These are also issues for discussion in supervision and sometimes with legal counsel. What about making sure that the treatment is appropriate to the client? If your program is an AA-based model, is that an appropriate program for an atheist? What if there are no secular programs available? What about treatment programs for specific populations? If there is no treatment program available that is specific to Native Americans or to gay, lesbian, bisexual, and transgender people or the Latino population, how do we ensure that clients get what they need? What about a client who has harm reduction or controlled drinking goals and your program is abstinence-based? How do you help that client? Again, not quick and easy answers, but ones that require thinking and discussion. And then in the chemical dependency field, there are programs that refuse to treat clients who are intoxicated. If they come to a group session, for example, they're turned away. Or if they are not sober, they are not able to continue in the program. Do treatment programs have the right to deny services in this way? And do treatment programs have the obligation to ensure that clients get home safely if they do turn them away? If relapse is considered a part of the disease process, then how can we punish clients for relapsing? How can we stop working with them when it's our job to increase their motivation to change? And can we be sure that a client is not valuing the goals of the program? Maybe they have a skill deficit that we need to help them with. So a lot of treatment programs are grappling with this issue of what types of clients they can serve and in what stage of recovery the clients are in. Excuse me. Another issue in the chemical dependency field is related to use of medications. So some traditional programs may have a policy against using any sort of mood-altering or mind-altering chemicals. But what about drugs that treat mental health conditions, or clients who are in chronic pain who have been prescribed opioids or benzodiazepine, or cancer patients that use medical marijuana? These are also questions that the treatment field is looking at, and again, not always easy answers. So this has actually been a presentation more about the questions and dilemmas that are out there than actually an answer to many of them. But as we have talked about, there are steps to follow when these sorts of ethical dilemmas arise. First of all, you should do before any ethical dilemma arises is have already cultivated self-awareness regarding your own history with chemical dependency or with whatever the issue is, your own values related to these things, your boundary issues, your needs, your cultural competency, your general competency in some of the areas that your clients might present with. And then seek counsel from colleagues and supervisors, consult the NADAC ethical guidelines and other relevant guidelines. You can even seek advice from the state licensing board. Obviously, you sometimes need to seek legal advice and use an ethical decision-making framework. And record a summary of the consultations that you've had and the decision you've come to in the client record. So it's not different than other ethical dilemmas in other areas of human services, except maybe some of the resources are different in terms of the licensing board or NADAC. And if you want to learn more about ethical issues specific to the chemical dependency field, here are some resources for you to consider.